right, welcome everyone to the Medicine Rehab Fitness Institute's first of what will be an ongoing webinar series that we're very excited about. And since it's our first, if we have any glitches, please forgive us and forgive me. I'm going to be kind of the one moderating this for the most part. And we're going to get into our formal introductions here in a second, but as you all know, this first webinar is titled Exercise Medicine, Bridging the Gap Between Medicine, Rehab, and Fitness. And I've known Sheila for, I think, about 5 years, maybe in that range, and Thomas for, I think, in the neighborhood of 4. And uh, I'll say something a little bit more after they do their introductions, but we are all very, very, very passionate about this pathway, moving patients from the medicine into rehab and then the rehab pathway into the fitness and wellness domain. Um, and I also just wanted to mention, because it definitely relates to this webinar, that the three of us we co-presented in 2022 at the American College of Lifestyle Medicine's annual conference in Orlando. It was a 3-hour pre-conference presentation on this topic. The title was a little bit different, but it was on this topic, bridging the gap between medicine, rehab, and fitness. And then afterwards, we created an educational video on really like the exact slide deck. So we created a educational course that's up on our website, which is www.mrfinstitute.org. And so I mentioned that because it's obviously we're biased, but it's an amazing course, and B, we'll be referring to that probably more than once during the course of this webinar. So in any case, with all that said, let's start with some quick introductions. We'll go medicine, rehab, and fitness, and then we'll get into just some short topics, and because we want to spend a lot of time on Q&A, if possible. So Sheila, you can go ahead and go first.
Okay, so everyone, I'm Sheila Hautbois. I'm an assistant professor at Shenandoah University in Virginia in the PA Studies program, and I practice lifestyle medicine for a concierge primary care, and I have also practiced for outpatient cardiology practice for 6 years.
And Thomas?
Yep, my name is Thomas Hammett. I'm a physical therapist by background, so graduated from PT school about 7.5 years ago from Duke University. I came into a career almost immediately in a clinic that was doing an integrated approach that I would call lifestyle medicine now, and didn't know what that was at the time. And have moved gradually on to really what is a medical director role for a set of outpatient lifestyle medicine clinics in the Seattle area. So good to meet all of you.
And I am Jeff Young, and I wear many hats, but to keep it brief, I'm about 30 years into my career. I have a bachelor's in kinesiology, a master's in exercise and sports science, and I'm currently a doctoral student in kinesiology, not pursuing a PhD. I'm going the EDD route, and I'm about halfway through the program, and actually just learned in the course that I'm in right now that I'm not going to be performing traditional research like a PhD would. It's something called action research, which I have a webinar coming up on 2 nights from now, which I'm going to be detailing what that's all about. But in any case, I also teach some courses at college here in New York City called the City University of New York, or CUNY York College. I teach strength and conditioning, um, sports medicine, intro to sports medicine and rehabilitation, nutrition and health, and a weight training activity course, which are all really right up my alley. And then lastly, I'll just say that I absolutely consider myself a strength and conditioning coach, I'm NSCA CSCS, or a strength and conditioning specialist. So I consider myself a strength and conditioning coach, but one who just understands how to scale strength and conditioning concepts, guidelines, and principles to clinical populations. So for people living with obesity, older adults, chronic disease across the spectrum of disease, and musculoskeletal conditions across the spectrum. So that's my introduction, and we're going to move into, in a second, we're going to move into Sheila talking briefly about the current state of physical activity in the U.S. and why it matters. But before we do that, let me also just say that Sheila and Thomas, and I wish we had time to just really talk about this in some detail. They are really different. I've worked at Duke University, UCLA, Mount Sinai, Beth Israel, and several private practices. I've worked with clinicians across a very wide spectrum of care in what would be considered world-class uh, institutions, and I have never met anyone like Sheila and Thomas. So I know I'm making their heads grow a little bit, but you're getting ready to see, not just in this webinar, but in our ongoing webinars, they are very different. They are absolutely outliers. So with that said, Sheila, go ahead and talk about the current state of physical activity in the US and why it matters.
Well, I don't think it's a surprise to anyone that there's a state of physical inactivity in the United States, not really a state of physical activity. We actually have a pandemic of physical inactivity, and most people are not meeting the minimum guidelines for physical activity. So, this actually increases everyone's risk of non communicable diseases and death. And we know that exercise can prevent and treat chronic metabolic diseases. It can treat physical pain and disability, sarcopenia or muscle loss, falls risk, and so many more things. But yet, 6 out of 10 people with chronic diseases do not even currently exercise. So, this is a huge treatment modality that is missing in the majority of people with chronic disease. So, what's the problem, right? Well, despite the potential for exercise to be prescribed and utilized to improve patients' health and well being, we don't think there's a medical pathway to exercise. There's no standard process to get patients exercising. You don't just write a prescription pad and say, here, go do it. So, there's a gap between the medical and fitness worlds. And I hear clinicians saying, well, I don't know who to refer to. There's all kinds of reasons, which I won't get into. But anyway, the problem is there's this gap. And most medical care as it's practiced today does not directly or adequately address the problem.
And I'm going to piggyback off that real quick before we get into our next topic and say that, again, and I know I'm giving a plug here for a webinar that's 2 days from now, but in this kinesiology doctoral program I'm in, like I mentioned a couple minutes ago, it's action research. And I am so passionate about what Sheila just talked about. And uh, I believe very strongly that part of the reason for this gap is that if you just look at the barriers to referral as a landscape, it can seem really daunting. So if you're not breaking it down to each actual barrier and using deductive reasoning and some critical thinking and creative thinking, but you're just looking at the landscape itself and you're seeing that, oh, lack of time and lack of finances and mobility issues and chronic pain and apprehensions and previous negative experiences, and you can go on and on, then that creates part of this gap between medicine, rehab, and fitness. And I'm really passionate about it. And I can't wait to get into more detail as to no, actually, if we use the stages of behavioral change as one of the things that we look at, and then also break the perceived barriers down, you start to realize that there's actually solutions for just about every single perceived barrier. So I don't know that we'll really have time to get into that today. It's not really the purpose of this webinar, but I just want to mention that as well before we go into the next topic, which is the three of us are just going to briefly speak about a practical strategy that's relevant to our specialty that you, the attendees, or anyone who's listening to this as a recording can apply right away. So again, we're going to go in the medicine, rehab, fitness order. So Sheila's going to start with her practical strategy, and then hopefully this will also lead to some questions once we get to open up to the Q&A.
Thanks, Jeff. So, something I do, and I believe every clinician, physician, PA, or advanced practice nurse should be doing is screen for physical activity during every visit with a patient. So, regardless of whether it's a new patient visit or a returning follow up visit, finding out what is the status of this patient's physical activity. If I don't screen for it, I don't know what they're doing, then how can I talk to them about it?
So, for me, Sheila, are you ready for me to take
Yes.
the floor? Okay, cool. So, for me, what I learned as a physical therapist and what Sheila was speaking to is established pathways to exercise. And there's really two formal established pathways to exercise in medicine. And one is to go to physical therapy, the other is to go to cardiac and pulmonary rehab. And there are some others, but those are the two primary insurance covered pathways to exercise. And what I learned about patients coming to physical therapy is they have all different kinds of beliefs about what they're doing there, but most of them are just hoping for me to fix their pain. Now, sometimes it's post-op, et cetera, but what if I made a set of assumptions about what I thought patients were doing there based on what the medical system has told me my job is, which is really to fix a broken body part. I I'm gonna miss the entire picture of that person's history of their movement and their understanding about their health. This is gonna sound really simple, and this is something I actually just talked with Andrew Mock about on a podcast recently. But we have to be asking people how they feel about their health, what they know about their current health state. Again, as Sheila was talking about their physical activity, and their willingness, really like the importance to make lifestyle change at that moment that they come and interact with me. And as physical therapists, I don't know if there's any rehab providers on here, but we can't look at our role as region specific, body region specific. So I'm not just responsible for rehabilitating a shoulder. I have the opportunity to help someone get more active, more physically active, and rehabilitate and improve the health of their entire body. Um, and it's a different lens. So I think that's where I'll pass it off to Jeff.
All right. Yeah, so I stole my uh tips from an article that's actually in the current American College of Sports Medicine's Health and Fitness Journal issue on professionalizing the fitness industry, and I'm allowed to steal it because these are my thoughts. So I'm not plagiarizing. And the article is titled "Developing Trusted Collaborative Relationships Between Healthcare Providers and Exercise Professionals." And so for the fitness professionals who are listening to this webinar, let me just start by saying that we have to recognize that part of the reason why there's a gap between medicine, rehab, and fitness is because of us. And we're a little bit of the problem, and we need to be proactive. And and it actually starts with really watching this webinar and then incorporating what I'm getting ready to say. So if you happen to work in a clinical setting, whether it's wellness facility or hospital or private practice or whatever, if your facility doesn't have in services or allow in services that you can both attend and perform, you should be doing that. So, uh, going back to um, 2006, when I was 10 years in my career and brought on into this Mount Sinai Beth Israel facility, I didn't even know what in-services were, and then when I was told that I was going to not only have to attend but present in-services, I got really nervous about it. And just for reference, an in-service is basically it's a staff professional development meeting on some hot topic. Like I worked in rehab, sports medicine, and rehab atmosphere for the most part. So it'd be like a hot topic of the month on maybe rehab for a low back issue or a knee issue or hip or something like that. And then I would perform in services to educate clinicians on the exercise side of the fence, periodization or proper programming, things like that, and how to merge the things I was learning about rehab and medicine precautions and special considerations with exercise science guidelines. So that's one thing you can do as a tip is you really need to get proactive in performing attending in services to help develop trust between yourself and the clinician. Another thing you should be doing, fitness professionals, is offering your training services to clinical staff. And this can occur within a clinical facility or outside of it. But the way a primary way to bridge the gap between medicine, rehab, and fitness is for you to use that as an opportunity to show clinicians your skill set, your knowledge, but also to learn, to be able to talk during the training sessions. This was huge for me in multiple facilities that I worked at. It was a really great way for me to learn the language of rehab and learn the language of medicine from a programming standpoint, from a special considerations standpoint, precautions, safety, stuff like that. Um, Another one is that you should set up standing meetings whenever possible at the clinician's preference and cadence based on their extremely busy workflow. Not that we're not busy either, but you need to take that in consideration. So even if it's once a month or once every 2 months or once in a quarter, it shouldn't be this complete disconnect between fitness professionals and clinicians. Set up a 30-minute standing meeting and use it as a way to collaborate on improvements, on the ways you can improve your interaction with each other, whatever that means. And that's actually a huge thing of what action research is all about. It's about looking at your situation, seeing what the problem or the problems are, and then collaborating with each other and working on solutions and staying in touch with each other and then reflecting back on what you did, the improvements you made, the problems that still exist. And it is a continual process, which is the reason why you should have standing meetings. And then the last two, very quickly, are clinicians want to know, have and be provided relevant feedback and outcomes on their patients. They want to know this, but you know, clinicians are different. Some want more detail, some want a little bit more quantitative, objective feedback. Some are more, no, I just want to know how my patient's doing from more of a qualitative and subjective standpoint, that their knees feeling better or life's getting easier, whatever the case may be. So these are the types of discussions you need to have and find out from clinicians what type of information is important to you, at what cadence, and then I will provide that for you. And then along with that is to share patient progress. So those are my tips and things that you should be thinking about. Again, it's so much easier to do this stuff when you're already working in a facility with a clinician and you see them walking through the hallways or face to face or whatever the case may be. It gets more difficult when you're working in a community setting, but you need to think outside the box and figure out a way. You need to pop into the private practice or whatever and introduce yourself and use the ACSM's exercises medicine um, handouts and guidelines to be able to connect with clinicians and things like that. But more on that maybe either later or for a future webinar. But those are my practical tips for fitness professionals and actually clinicians too, because you should be thinking about how to collaborate with fitness professionals. So the last thing we're going to do before we head into Q&A for hopefully a good 15-20 minutes if we have the interest, um, is some debunking common myths and misconceptions. And each of us is going to tackle one or two myths. And Thomas, since you're running out of time, I know it's a little out of order, but maybe you could go first on this one and then Sheila's next.
Yeah, it's great. This is going to be an easy one, but I think from the medical provider standpoint, the idea that we don't have time to talk about physical activity and exercise would be maybe my biggest myth to debunk. And I don't even know if it's a myth more so than a commonly held opinion, and maybe a barrier from those that are afraid to try. And I'll give you an example, because I think sometimes the initial conversations around this stuff can be really easy. It's just understanding where people are coming from. We give Our cardiac rehab program has 12 weeks of education embedded within the program itself. And what we do is watch a 3 to 5 minute video, and then have the participants reflect essentially. So it's like the flipped classroom model, if you're familiar with that. Not groundbreaking stuff, but it's pretty cool to be able to do it with the general population in cardiac rehab. And the video is on resistance training. We spent 3 minutes watching it, and the first question we got afterwards is, well, I don't know why we do this. Isn't the best kind of exercise walking? And, you know, I thought that was a really great question to ask, because I think it's a really commonly held belief in the public. And it highlights a really simple misunderstanding between what physical activity versus exercise is. And we have time to talk about this stuff. We have time to help people understand that exercise is dosed and prescribed for the individual to achieve a goal versus physical activity is any movement you do. Like if you help someone walk away with that kind of knowledge, you've done it. And that took me, I don't know, 10 seconds to explain just now. But helping understand where people are coming from and what we're essentially need to gain from their perspective. I think that would be my biggest. It'd be my biggest myth to say we don't have time to talk about this stuff. We just have to make the time to do it. So that's what I'll say and pass on to Sheila.
Are you passionate about bridging the gap between medicine, rehab, and fitness? At the Medicine Rehab Fitness Institute, we provide in depth resources to help clinicians collaborate with qualified fitness professionals and optimize exercise for everyone. Head to www.mrfinstitute.org to explore our full course on moving patients through this pathway and learn how you can add lifestyle medicine or medical fitness services to your practice. Visit us today to dive deeper into the future of exercise as medicine.
Well, my biggest myth, and something I hear a lot, is that clinicians feel like they should be the sole source of a full exercise prescription for every patient. And I feel like we have a whole profession that has gone to school and learned how to do this in depth, and we have not. Therefore, we must learn how to refer and not be the sole source of writing prescriptions that are outside of our domain. There's so much to learn, and I can help a patient get started. If they're sedentary and they need to get a little bit of activity, that's in my domain. I can absolutely do that. But I cannot put someone on a progressive strength training regimen that caters to their personalized medical fitness issues in a way that a qualified fitness professional can.
And I am going to briefly mention two myths and then we'll open it up to Q&A. The first myth that is something that unfortunately, well, actually, with both of these, I could probably go on. You can already tell I'm a talker, and I could probably go on for a long time about, but that's not the purpose of this webinar. But the first one is that we need to design condition specific programs. And what I mean by that is that there's a myth that we need to design one type of program for someone with diabetes and another type of program for somebody with osteoporosis, another type of program for someone with hypertension, and and you can go on and on. That is just not the case. And to give it a little bit of clarity, even though I can't go into a lot of detail, about this. First of all, again, on our website, we have video, educational videos on this stuff that go into a lot more detail, and I'll be covering in a lot more detail in future webinars. But there's a general blueprint that applies to, there's always going to be outliers, but generally speaking, there's a blueprint that applies to pretty much everyone. And that is you meet the person where they're at, no matter what condition they have. You determine their capacity, you ease them into, and I'm right now I'm just talking about strength and conditioning more specifically, as opposed to aerobic program. Because aerobic program, it's much easier. You could just start off with walking or something that's light like that. But with resistance training, I like to start people off with a physical therapy like approach where it's kind of low volume, low intensity, low variety, low frequency. Use that as a way to determine their pain-free available range of motion, the exercises that are appropriate for them. Use rate of perceived effort scales to determine their capacity of what they can tolerate from an intensity standpoint, etc. And then pretty much everyone can be put on what's called a periodized program. And again, unfortunately, I don't have time to get into too much detail into that. But what I will say is that last week, I had arguably one of the premier strength and conditioning researchers in the world, Dr. Bill Kramer, present for my strength and conditioning students at CUNY York College. And one of the things that he was hammering home to my students, which is relevant here, is that it doesn't matter uh, whether you're an athlete, a client, or someone's client or not. It doesn't matter where you lie on the lifespan. Could be in your 20s, it could be in your 90s or anywhere in between. And it also doesn't matter for the most part what medical or musculoskeletal conditions you have. Pretty much everyone should be at the very least improving their conditioning, their lean muscle tissue or muscle hypertrophy, their power to some point, even with older adults to help catch yourself from falling, and especially strength, because strength is really a foundation of movement. So, and we can do that using a periodized approach. So, across the spectrum of conditions. That's something I actually used to get confused by when I was at Mount Sinai and first learning this stuff. And I would get referred patients across the spectrum of um, medical maladies, and I wouldn't say anything to the clinicians, but the way I was actually designing programs was in a periodized fashion where I would start them, I would ease them into the program, and then I would start them in a higher repetition range with lighter weight, like maybe 12 to 15 repetitions per set. I'd keep them there for a phase, and then I would drop them down to 10 to 12 and keep them there for a phase, and then 8 to 10, and maybe 6 to 8, depending on the situation. And that applied to everybody. So there's one myth that you can tell I'm very passionate about. And the last one, which I'll be more brief about, is that we need to, with special populations, and I'm defining special populations here as older adults, like 55 or 60 and older, which unfortunately applies to me now. Those living with overweight or obesity, chronic conditions, and or musculoskeletal conditions, that we need to perpetually baby them and be too afraid, for lack of a better word, of progression and intensity. And for the attendees here and for the viewers of the recording, I was the founding chair and I'm the current vice chair of the National Strength and Conditioning Association's Special Population Special Interest Group. And our group was really founded on this tenet that we don't need to be afraid of progression. We don't need to be afraid of intensity. And again, you meet the person where they're at and you do baby them at first, absolutely, but then we want to continue to progress. And it doesn't and we are really doing a disservice to older adults, those living with overweight and obesity, those with chronic disease and or musculoskeletal conditions, by continuing to what's really called underdosing them, and starting with the low volume, the low intensity, the low variety, which and the low frequency, which is appropriate early on, but then continuing with that and not progressing. So those are my two of my biggest passions and two myths in the fitness industry. And actually in medical medicine, rehab, and fitness, that we need to baby people with who fall into that special population category. So with all that said, let's open it up to questions, comments, disagreements, debates, however you want to do it. And yeah, you can just raise your hand or chime in however you want. And actually, you know what? Let me take a second here. One of the attendees is Elise Freeman. And I want to introduce, Elise, I want you to allow you to introduce yourself here real quick. I met Elise when she was a student at Cal State Long Beach, correct? Cal State University Long Beach.
Yep.
And I have a virtual medical fitness service that provide, since it's virtual, it's to clinicians across the country. And I brought Elise on as a friend, a colleague, and she's amazing. So Elise, go ahead and uh, introduce yourself real quick.
Yeah, so hello everyone. So as Jeff said, I graduated from Cal State Long Beach. So I got my master's degree in exercise science. That was my background. Prior to that, in my bachelor's degree program, I did physical education with a concentration on pre-physical therapy. And so when it comes to my background, I like to consider myself heavily focused right now on physical inactivity and making sure we get people, just as Sheila was saying, moving. So that's one of my passions. That's a lot of what my research was built around. One of my focus my focus when it came to my thesis was a particular population, which was office employees. And so I targeted office employees because, of course, they're sedentary. And so, and when we look at office employees, it doesn't just subscribe to just administrative assistants. It can subscribe to attorneys. It could subscribe to librarians. It could subscribe to so many people. It could even subscribe to gamers. for those who may be interested in esports. And so just finding ways to break up those sedentary habits and get more activity throughout our day. And so one of the things I do with Jeff and with Sheila and with Thomas, who just stepped off the call, is work with these patients who get referred to us and figure out ways to change the narrative when it comes to their mindset and their perception about exercise, and breaking it down and really breaking down the difference between physical activity and exercise, and also introducing to them concepts of strength training and really understanding what that means and making it in layman's terms, in a sense, to where it's relatable, easy to understand, fun, and then eventually progressive. And so the thing is, I worry about the progressive part. All I need is their commitment. And so it's one thing that's been very enjoyable. And I've been blessed for the opportunity to join this elite group of people and just have them as mentors. And so it's something I'm very excited about doing and something I'm very passionate about as well, too. Happy to be here and happy to share.
And happy to have you here and part of the team. All right, so with that said, does anyone have any questions or comments or topics for discussion?
Hi, can you guys hear me?
Yes, hi. Is it Alina?
Elena, yeah. I'm I'm reporting from my walking bed actually. I was walking on my walking bed while listening to this. But I'm a PA that practices predominantly in lifestyle medicine and obesity medicine. And so I was curious to kind of what each of your responses are typically to patients who may say that they can't exercise or they have XYZ limitation that precludes them from exercising, and sort of what your approach is to that sort of scenario.
Yeah, so that's a good one. I see a lot of patients with obesity. Um, and I have a conversation with them about any activities that they have liked to do in the past, because that tends to bring up happy memories of something, like I used to like to dance or I used to like to such and such. And then we talk about maybe ways, like, are there any ways that you could get back into that activity even if it were modified? Um, we also talk about, believe it or not, I'm just going to make up a number. 95% of cases, the patients with obesity are willing to try some strength exercises, even if it's uncomfortable to walk or do some other kind of cardio. So I've had people who've tried rowing or biking, and they just said, like, physically they're not comfortable doing it because their body habitus, the rowing, their front is in the way, or biking, same thing. And when I talk about, well, what do you think about strength training, like maybe some bicep curls, triceps, some shoulder exercises, to sit to stands, these types of things, they're like, yeah, I could do some of that stuff. So then that's when I refer them to Jeff and Elise and get them into a program. If I can get them doing a little bit and they get that self confidence and see that they can do something, because I think a lot of times they have a belief that I can't exercise. But if I can get them doing something a couple days a week, even if it's walking to the mailbox to get the mail and doing some bicep curls or something like that, and then I can say, all right, great, you're ready to, you know, have somebody help you with a program that is going to be tailored to you and sensitive to your medical conditions. I hope that answers your question from my perspective, and maybe Jeff and Elise can chime in from the fitness training perspective.
Yeah, I'll start and say that I'm going to be a little bit ambiguous with my answer, just because again, in two days or 2 nights from now, I'm going to have a very detailed webinar on this that you can either attend. Like, it's actually the purpose of the webinar in 2 nights is to answer this question in a lot of detail, that you can either attend or you can watch the recording afterwards up on our website. One thing I'll say is that this is actually a reason why it's so important that clinicians exercise, because then you can use yourself and your own successes, right, as part of the way to help engage with your patient and give that personal feedback as well. But one of the things, I think, one of the ways I want to answer your question, maybe to entice you and listeners to check out the webinar that I'm going to have in 2 days, is I think that it'd be good to start with trying to determine what stage of behavioral change that the patient is in first. And I'm actually working with some clinicians with the who are part of the Minnesota Obesity Society, several of which who are PAs. and we're working on an action research project that I'm doing for this course that I'm in right now in this doctoral program. And we're starting with actually some intake forms. So kind of it's actually multiple intake forms, um, which we're working on trying to streamline that, which is part of what action research is about. But currently, it's a couple of different research intake forms as a way to try to get a sense of what the barriers might be and what their experience is with aerobic exercise, what their experience is with resistance exercise, with lifestyle, with the components of lifestyle medicine, etc. So starting with intake forms as a maybe a preliminary way to categorize the patient. Maybe you already know the patient because they've been seeing you for a while, and so you just know intuitively what category they fall into. But anyways, then there's going to be three categories that you're focusing on: pre-contemplative, contemplative, and ready prepared. If they're pre-contemplative, then the way I look at that is you still need to subcategorize that because they may be pre-contemplated because of some sort of severe or uncontrolled condition where, yes, we are not worried about referring that person right now because we got to attend to that first. But a lot of times people, like Sheila alluded to, are pre-contemplative because they're either uninformed or misinformed. And so a lot of times just informing them um, can help move them into that contemplative or ready prepared stage. So, and then that gets down to my next thing, which is or two other real quick things, and that is again looking at each barrier. Like I don't have the time, uh, and really looking at that and then educating yourself. Oh, there's something called exercise snacks. Now you have a conversation that you can work with them, right? Or I don't have the finances. Well, as clinician, as Sheila, and I'm going to be speaking for you here in Sheila, and then Thomas if he was here. But their view, which I fully agree with, is that for the most part, it's not your job to worry about your patient's finances. You're not their financial advisor. Your job is to get them to us, the fitness professional. And Sheila, you can correct me if I'm wrong here, but get them to the fitness professional for the initial consultation, and we will take it from there. Now, if you happen to know something, some intimate details about their financial situation where they literally can't, and you know that they literally can't even afford to pay their electric bill or something like that, then that's a different situation. My point is that you use the intake forms, your knowledge of the patient, um, and your conversations to appropriately categorize them into a stage of change. And don't just assume that if it seems pre-contemplative that that's a insurmountable barrier because many times it's not. And then once you get them to contemplative and ready prepared, now it's just a matter of what kind of conversations are you having with them. Because if they're contemplative, they're on the verge, so it's just about the conversation and understanding how to utilize motivational interviewing. So Sheila, with all that said, do you have any additional things to say on anything that I mentioned?
I have to agree with you that there's a lot of misinformation and uh, uninformed going on. I had a patient the other day I saw for the first or second time, and so we were discussing. Usually, I don't push exercise, right? So we talk about it. I bring it up in the first meeting, but then I'll come back to it the second time. A lot of times, we're focusing on some other things first. But she said that she was going to start jogging. And this is a patient with extreme obesity. And so I had a gentle conversation about the stress on leg and hip joints and ankle joints with the extra weight, and how maybe if she really wants to jog, we can hold on to that goal for the future, but that might not be the best type of activity right now because it could risk hurting a joint, and then she might not be able to perform any physical activity. And she had no idea. She really was like, "Really?" And we talked about the extra force on the knees, and she was like, "Wow, that makes total sense, but I've never heard that before." And it was incredible to me that somebody didn't realize that carrying extra weight would put extra stress on joints, and that jogging would put more stress on knee joints than walking, for example. So I think there is a lot of disinformation out there and mis under information.
Do those answer for the most part? Good. Does, does anyone else have any questions or comments we probably do need to wrap this up in the next 5 to 7 minutes if possible. So if anyone else has any questions or comments.
Can I add to that too? In the talking about the 'cause my dog's barking, of course, right when I start talking. Um, as far as whenever you speaking to people about like where they are, barriers to change, like using motivational interviewing, and even like and especially the motivational interviewing, I think is something I've really been working on because I do virtual cardiac rehab and just cardiac rehab, and then I have my own clients that I'm working to build up my network in a rural area and finally get a hold of a physical therapist that understands what I'm trying to do, and he has the same vision anyway. But something that I find too is reframing. Like I had someone today that was like, "Well, I don't." He wants to lose weight. He might have long COVID. He can't get his. He wants to exercise more, but he's not going to be able to because he doesn't even know what his like what does that look like for him. In his mind, he needs to exercise more to lose weight. And so I'm reframing it to the point and like kind of I guess what Sheila was talking about, kind of to the point of going, well, like for her it was, let's incorporate more low impact for the joints and then build you up maybe to running later and then maybe some strength training for bone density. For this guy, I'm like, well, let's refocus on your nutrition. Like, so what are your barriers for so his is going to be he's got low functional capacity, right? He's got these other issues that are going on and he seems to be like at a you could tell he was frustrated for his change. So I was like, well, what about, changing let's get you in some health education classes and talk about, your nutrition and then do more frequency and bouts of exercise as opposed to like overdoing exercise. Does that make sense?
Mhm.
And so I think that that's a really big deal in reframing for people. And anyway, just piggybacking, and then like the motivational interviewing has been such a game changer for getting people for behavior change, like moving them to that other stage from preparation to action, and focusing more on what they can do than what they can't do. Getting to know them and things like that. So that's all I was going to say.
Every patient has uh, areas where we can increase their understanding, and it provides power. It empowers them to be able to take charge of aspects of their health. And if there's certain aspects they can't control today, but we can give them the power over other aspects, and that's going to increase self-efficacy, which is going to improve all the other aspects later on. Every aspect is intertwined, and self-efficacy can grow, right? So when we allow them to have little goals today that they can meet, then next week we're going to be able to hit other goals that they can feel like they're going to be able to meet too. I was thinking when you were talking, Claire, that I've had patients with peripheral artery disease who came in and told me that they can't walk. And I was like, well, when you say you can't walk, what does that mean? And then they define how like it hurts, right? And I'm like, okay, well, how long can you walk before it hurts? Right? And you dig into that. Like, you don't just believe that it's hurting right when they take the first step. And sometimes they'll say something like 10 minutes, right? Or 15 minutes. And then I'm like, okay, well, then I want you to walk 10 minutes and sit down and rest. And then could you do that 10-minute walk again? Like maybe before lunch? Yeah, I can do 10 minutes without it hurting. Well, how about if you did 10 minutes again before dinner? Could you do that? Yes, I could do that as long as you mean you're not going to ask me to do more than 10 minutes of walking? And I'm like, no, not at a time. If that's where it hurts, that's where we're going to pause and rest. And then we're going to increase the frequency of that so that you add up to these times. And in every case, if they start doing that, they're able to increase the amount of time they're able to walk over weeks and months. And, you know, pretty soon they're walking 20 minutes without any pain.
Yeah.
And then they're seeing, wow, like this is incredible. But if they had that belief that I can't walk more than 10 minutes, they're never going to walk more than 10 minutes unless we talk about that.
Well, limited beliefs guarantee limited outcomes. But I think a common misconception too that I help with patients with is like it has to be this much for it to count, right? I have to go to the gym for 30 minutes to an hour for it to count or to be worth it versus I try to just get them to the door. Like, you just need to get in and walk in. If you want to start doing something and then turn around after 5 minutes and go home, great. That's 5 more minutes to your week than you otherwise would have had you not done it at all, or had you not done that little bit of movement.
That was actually gonna be one of the myths that I had written
Oh,
written down. It really was. It was gonna be that, a myth that so many people believe in is a giant barrier to exercise is you have to chase soreness. You have to be sore. You have to be sweating like crazy. You have to exercise for an hour or it just isn't worth it. And so again, this is why we need to have these webinars and get this education out there because just like Sheila said, we it's our job as professionals, whether you're a clinician or a fitness professional, to look at basically what we're just doing right now. Look at these barriers and realize that, oh, there actually are solutions and become informed ourselves so then we can then inform the client or the patient, and then everyone is informed, and then the effect it has on your patient and on public health would be huge. And I hate to do this, but the truth is, we are about 51 minutes. Well, we started 5 minutes. We're about 45 minutes into this, and we really do unfortunately need to wrap this up. So, Michael, did you have any questions or comments?
I wrote down a lot of stuff
Okay.
and I really agreed with everything said here. Most people here don't know, in fact, nobody knows me, but I come from a very different side than all of you. And I'm engaged in a project right now that speaks to medicine meeting fitness. And I will just share that I see a continuum of fitness on one end, medical fitness and physical therapy on the other, and a gigantic gap in the middle where I think there's a great deal of good work to be done. And for those in the fitness industry, a lot of money to be made. Because as we all know, 80% of Americans don't go to the gym, and there are reasons for that. Maybe in a future meeting, I'll dive into this more deeply, but I agree with everything I've heard here today. I'm really glad to hear all these.
Awesome. Everyone, thank you so much for attending. And again, keep your eyes open because this is the first of what is going to be an ongoing series. And we have a soft partnership with the Medical Fitness Association. So on occasion, we'll be doing some joint webinars with them. And we always have joint podcasts with the Medical Fitness Association every other week where we bring in amazing guests. So just keep your eyes open, stay tuned. Thank you all for attending this one and to be continued.
Thanks,
Thank you.
Chef.
Nice to meet you all. Take care.